In this video, I'll explain Centanafadine, a new non-stimulant ADHD medication that targets norepinephrine, dopamine, and serotonin, and why that third pathway might matter for real-world ADHD. The current narrative for ADHD, it's dopamine and norepinephrine, or noradrenaline. Fix attention, done. But that story doesn't match with what a lot of people actually struggle with. The focus is one piece, the regulation is the bigger piece. I'm Dr. Sanil Rege, consultant psychiatrist and educator. I've created an extensive curriculum for ADHD excellence in clinical practice. And clinically, I've treated thousands of patients with ADHD. By the end of this video, you'll understand what Centanafadine is, why serotonin has re-entered the ADHD conversation, who might it suit, and what to watch for without the hype. Before we jump in, Centanafadine is not yet FDA approved. It's just received priority review status. When it comes to thinking about ADHD treatment, it's important to think about two rules. Rule 1, ADHD isn't just about can't concentrate. It's a neurodevelopmental pattern that can show up as attention instability, plus impulsivity, emotional reactivity, sleep-wake fragility, and anxiety-like arousal. Rule 2, with new medications, people can sometimes look at medications as a panacea. So either over-celebrate it, or in some cases, if they don't work, dismiss them. We're not taking either route. We're taking a clinician's approach, a balanced one. We'll try to understand what the mechanism is, why it matters, who might it fit, and of course, the cautions. As always, this is an educational video, not personalized medical advice. So let's start off with the mechanism. What's new about Centanafadine? Centanafadine is a non-stimulant ADHD medication that is positioned as a triple reuptake inhibitor, an NDSRI. Norepinephrine, dopamine, serotonin, reuptake inhibition. Let me explain this in simple terms. The neurotransmitter concentration in the synaptic cleft is actively regulated, and one regulatory aspect is what's known as transporters. Think of them as mop-ups. So what they do is they take up the neurotransmitters from the synaptic cleft into the presynaptic neuron. What Centanafadine does is it blocks these transporters, and therefore there is a higher concentration of these neurotransmitters in the synaptic cleft. So norepinephrine is linked to task activation, vigilance, alertness, dopamine, motivation, reward-based persistence, the stick with it, the engagement, the drive. Serotonin, emotional tone, impulse control, and stress sensitivity. We know that most ADHD medications live in a two-system world, particularly the stimulants, methylphenidate and dexamphetamine, covered here. Centanafadine is one of the first that brings serotonin into the story in a direct way, through reuptake inhibition. Here's why serotonin is back in the ADHD conversation. Now, we know from the depression story that we're not looking at serotonin imbalance or chemical imbalance or serotonin causes depression. Similarly, we're not looking at serotonin deficit causes ADHD. That's not how we think about it. Serotonin is a modulator. It influences how other systems behave. And serotonergic pathways are wired into the same brain regions we care about in ADHD. Prefrontal cortex for planning, inhibition, executive function. Striatum, habit, salience, action selection. So when people say ADHD is about dopamine and noradrenaline, they're not wrong, but it's not the complete model because several lines of evidence have been pointing to serotonin for a while. So let's look at some threads here. First, biology and behavior. Serotonin is strongly involved in impulsivity, reactivity, frustration tolerance, and sleep-wake regulation. These aspects map onto the ADHD domains where patients say, I can't slow my brain down. I overreact. I act before I think. I'm wired but tired. 2, genetics. ADHD is highly heritable, and we see genetic signals across multiple neurotransmitter systems, not just dopamine and norepinephrine. They also include serotonin transport and receptor pathways. 3rd, comorbidity. ADHD is a highly comorbid condition. commonly entangled with anxiety, low mood, depression, insomnia, substance use vulnerability, migraine, gut symptoms, broader somatic sensitivity in some patients. Here's the interesting thing. Serotonin has roles in both the brain and the body, which gives a plausible biological bridge for why ADHD can look so different across people. And we've always known that 95% of serotonin is produced in the gut. So here's the key clinical aspect. Serotonin may be parts of why ADHD is not just an attention problem, but rather a regulation issue. And Centanafadine is interesting because it's trying to match that broader reality mechanistically. But of course, mechanism needs to translate to clinical practice. So what do we know from trials? Here's what studies suggest. Not too much detail, but just a broad gist. Across studies in children, adolescents, and adults, Centanafadine has shown improvement in core ADHD symptom measures compared to placebo, effects showing up early in treatment in some trials, and a dose pattern where higher doses performed better than lower doses. So it seems like it is a legit non-stimulant option, but also it does not appear to beat stimulants for raw symptom reduction. It sits closer to other non-stimulants in overall strength, so therefore might be a good adjunct to overall ADHD treatment, another tool in our armamentarium. I've covered non-stimulants in a video here. Where it might win is on tolerability and misuse risk in the right patient. So what's the tolerability profile? Commonly reported side effects included reduced appetite, nausea, headache, fatigue, sleepiness, rash, and sometimes abdominal discomfort. And importantly, it's being positioned as a non-stimulant with no obvious abuse or diversion signal in trial settings, which matters in a world where clinicians have to balance ADHD treatment against misuse risk. Since I mentioned serotonin, you might ask, so does that treat mood? Not necessarily. Now, while Centanafadine's serotonergic activity creates a reasonable hypothesis that it might help some patients with emotional volatility, irritability, anxiety, sleep fragility, and therefore have maybe secondary benefits, Centanafadine is not an SSRI. It's not an antidepressant. So therefore, this is about ADHD treatment, not mood disorder treatment. So where might it fit in practice? And we don't know enough because we know when medications move from the trial world to clinical world, effects might be very, very different because patients that we see don't exactly fit trial patients. So if you're a clinician, a very informed patient, here are situations where Centanafadine may become relevant if approved and available. One, when stimulants work, but the trade-offs are too high, such as sleep disruption, appetite suppression, rebound irritability, heightened anxiety, cardiovascular caution, misuse risk. Or two, when you want to start off with a non-stimulant. Here, a triple reuptake profile may give the best of both worlds. The noradrenergic, dopaminergic activity, but the serotonergic pathway for the non-stimulant regulatory aspects. Third, when ADHD looks like a dysregulation phenotype. We're not talking about major depression, anxiety disorder, but rather heightened reactivity, impulsive urgency, sensory overload, sleep instability, stress sensitivity. That's where we start thinking about serotonergic pathways, and therefore Centanafadine may help this phenotype. And the quotient in clinical practice are likely to be the same in terms of caution with marked agitation states, bipolar spectrum vulnerability, complex polypharmacy, significant cardiovascular or appetite, weight concerns. So let me summarize Centanafadine so that we can remember some key points. Centanafadine is a non-stimulant ADHD medication with a triple reuptake mechanism. It's an NDSRI. The new part is not just a new name, but the consideration of the serotonergic component, which maps onto regulation domains that many patients struggle with. Trials suggest it's a credible non-stimulant option with common side effects like appetite reduction, nausea, headache, fatigue, somnolence, and rash. The way I see it, it likely won't replace stimulants, but it may fit specific phenotypes where tolerability, misuse risk, sleep, or emotional reactivity are central. So there's one thing to take away from this video, it's this. ADHD isn't just a problem of paying attention, it's a problem of regulation, attention, impulse, emotion, and sleep. And that's why a medication touching serotonin is worth paying attention to, even if it's likely not going to be a magic pill. We don't know exactly what happens to this medication and when it's going to be available, but I've covered stimulants and non-stimulants, including lifestyle strategies in ADHD, which you can explore in this ADHD playlist. If you're a clinician and you like this style of teaching, mechanism first, clinically grounded, translation from neurobiology to clinical practice, that's exactly what we do inside the Academy by PsychScene. We go deeper into ADHD phenotypes, medication selection, and how to measure real functional outcomes. We've had over 1,000 clinicians take these courses with great feedback. I'm Dr. Sanil Rege, and you're watching the Dr. Rege channel. If you like this video, hit the like button and subscribe to our channel. I look forward to seeing you in the next video. Until then, stay curious. Bye-bye.